Okay, dear Chair, it's very good for us to join this session together, and then it's my honor to be invited to give this presentation. The topic I'm going to present is the risk assessment of patients with acute coronary syndrome. I'm Dr. He Pengcheng from Guangdong Provincial People's Hospital. And when we talk about risk assessment, actually in the first place, we need to evaluate the risk when we see the patient in ED or in our cardiology department. So I would like to talk about the risk assessment before or during hospitalization first. Actually, I think all of the audience here is quite familiar with the TIMI risk score. Actually, it was introduced when I was trained as a cardiology fellow. And in my point of view, I think the TIMI risk score is very simple and is easy to use, but it also has some weaknesses. The first one is that we can see here, actually the variables included in the TIMI risk score, less than half of them is able to reflect the real-time status about the patient, like only ST elevation, severe symptoms, and elevated cardiac markers. So this is the first weakness I want to point out about TIMI risk score. The second one is that when it comes to the outcome, you can see here the data developing the TIMI risk score. Actually, they focus on one individual outcome, that is urgent revascularization. Nowadays, we know that actually after we evaluate the risks of patient, we will suggest the patient undergo emergent or urgent PCI if the risk is very high. So nowadays, we don't think urgent revascularization should be still as one of the individual outcomes that we should pay attention to. So, and then we have GRACE score. Actually, we can see here, actually GRACE score has included more variables that is able to reflect the real-time status for patients with ACS, which include the heart rate, the blood pressure, and of course, the elevated cardiac biomarker as well. Furthermore, the GRACE score also weighs the different variables by giving them different points. Now you can see here, actually, when it comes to age, GRACE score has given different points to the different age. So that means that it's reasonable for us to presume that GRACE score can predict the risks of patients with ACS more comprehensively and more accurately. That's why nowadays GRACE score has replaced TIMI score as the first-line risk evaluation tool for patients with ACS. However, as we know, TIMI score was developed from the study focusing on the outcome only 14 days. And then when it comes to GRACE score, we can see here the data was developed from outcome at 6 months. That means that probably it's okay for us to use TIMI score and GRACE score to predict the short-term outcome for patients with ACS. But when it comes to long-term outcome or long-term risk assessment for patients with ACS, probably it's reasonable for us to consider other variables. The first one I want to talk about is plaque healing. We know that plaque rupture or plaque erosion is the main reason for ACS. So after the rupture and erosion of the plaque, there have different pathway for the plaque to develop. The first one is that the plaque can heal with time, and then the second one is that the plaque just fail to heal with time. So in this case, the patient is more likely to have an recurrent ischemia event if the plaque fail to heal with time. So how can we determine or how can we decide which part is more likely to heal and which one is locked. Now we know that we have lots of intracoronary emitting tube like iris, especially OCT, which can provide us with detailed information about the plaque with very, very high resolution image. But you might ask that, okay, is it necessary for us to for us to do the repeat check of iris or OCT for patient again? Probably not necessary, right? Because from some research, now we can see that actually we can determine whether the plaque is more likely to heal or not at the beginning. Why at the beginning of the occurrence of ACS? If we do OCT checks during the index coronary angiogram, we will find that actually this study tells us that the ruptured plaque is less likely to heal, while the erosion plaque is more likely to heal with time. So that means that if the OCT check told us that the plaque rupture is the major reason contributing to ACS, probably it's reasonable for us to put the patient on more intense lipid lowering therapy, more longer DAPT therapy. So we don't have to do the repeat OCT check during the follow-up again and again. So, and then how to achieve the plaque healing, okay, more quickly. Now we have some research telling us that actually we can achieve plaque healing by more intense lipid-lowering therapy, which includes statins and, of course, PCSK9 inhibitors. Furthermore, there are some evidence, some clinical trial telling us that actually patients with ACS can benefit from some kind of anti-inflammatory drugs. Okay, I think based on the findings from this study, I think probably the promotion of plaque healing by anti-inflammatory drugs could be one of the major mechanisms contributing to the better outcome when patient was put on anti-inflammatory drugs. And then when we talk about lipid profile, we always pay attention to LDL-C. But now we have seen lots of patients with residual risks. So I think it's time for us to pay some attention to triglyceride as well. This study shows us that triglyceride level actually is an independent predictor which is associated with the both short-term outcome and long-term outcome. Okay, for patients with higher triglycerides levels, actually the long-term outcome is worse than those with lower triglycerides level. And then now we are talking about revascularization. We all know that just like I said just now, actually now we individualize the patient's management based on the risk stratification. So for those with ACS, actually in China, most of them will undergo revascularization, revascularization in the catheter lab. Actually, there are some studies telling us that actually this is beneficial for patients with ACS. For the primary composite outcome, revascularization is able to lower the ischemia events, and for individual outcome like cardiovascular death, revascularization is able to lower the death rate in this population. This is a little bit different from the findings from ischemia study. We know that in ischemia study, revascularization failed to benefit patients by lowering the mortality. But this is not the case for patients with ACS. So I think this is one important difference I want to point out when it comes to different findings in between ischemia study and other studies about patients with acute coronary syndrome. And then I I am an interventional cardiologist. So actually in my clinical practice, I tend to pay attention to more attention to the coronary anatomy. But we are also in cardiology. So we need to put attention to to the function of other organs as well. First of all, it should be heart function. In this study, we can see that, okay, for those patients with normal heart function, actually it's less likely for them to suffer from recurrent ischemia event as compared to those with impaired heart function. This reminds us that for patients with coronary artery disease, like if we have a patient with three-vessel disease, but at the same time with very, very low EF, like less than 25%. So what should we do for this patient? Should we just need to do the revascularization, especially complete revascularization for this patient, or we should consider other options? So I think it's reasonable for us to determine the amount of viable myocardium in the first place before we should suggest the patients to undergo whether PCI or other management. So if we find out that actually there is large amount of viable myocardium, I think it's reasonable for us to suggest the patient to undergo heart implantation rather than revascularization. So this is about the heart function, the role of heart function, the impact of heart function on the outcome of the patient. Another thing we need to consideration is renal function. We know that actually in this study, we know that actually for those with impaired renal function, the likelihood of all-cause death is almost threefold or even fourfold higher than those with normal renal function. So what is the implication in our clinical practice? That means that for patients with coronary artery disease, especially for ACS, while at the same time with impaired renal function, we should balance the risks of our management about the coronary artery disease only, and we should also balance the benefit of the patient, whether it can benefit from revascularization therapy. And now it's well known that this patient is more likely to have contrast-induced injury when we talk about the renal function. So if we are able to do revascularization for this patient, but at the price of worsening the renal function in the future, I think in this case, we need to get the patient involved in the discussion and then ask the patient or even his family member to make decision together. And then by doing that, probably we can, make a good choice for the patients, especially when the long-term outcome is considered. Okay, finally, let's summarize my presentation today. Nowadays, many tools and variables have been developed to evaluate the risks for patients with ACS. But as a cardiologist, we should not only focus on the short-term outcome. We should also pay attention to the long-term outcome as well. And then nowadays, we have different variables like heart functions, renal function, which has been proved to be useful for us to evaluate the long-term risks of patients with ACS. Thus, further facilitates us to make an optimal decision about the long-term treatment of these populations. That's all of my presentation. Thank you for having me again. Thank you.